I'm Sanjay Bhagani. So for the next 20 to 25 minutes, I thought we should start the whole program off with just looking at the basic attributes of the integrase transfer inhibitors as treatment option in first-line therapy for HIV. So these are my disclosures. So what I'm going to try and do for you is look at the mechanism of action, talk a little bit about the activity against HIV, and then show you some data in terms of head-to-head as first-line therapy. We'll discuss a little bit about the metabolism and drug interactions, talk a little bit about the overview of tolerability, and then its place in current guidelines. What I won't go into detail on this particular talk is using dual treatment, and you have a lecture on that later this morning. Pregnancy, resistance, and detailed toxicity, all of which will be covered for you during the day. So let's start at the very beginning, and you are all very familiar with this, but this is the life cycle of HIV. You know it's unique in that it's a retrovirus that reverse transcribes and integrates into the host genome and perpetuates its activity through that. So one of the important steps in HIV replication is the integration into the host genome, and this is facilitated by virally encoded and virally made integrase enzyme, which has a number of important rules, but one of its most important rule is to facilitate the transfer of the complementary DNA from the complex into the host DNA. And this is where integrase transfer inhibitors actually work. So I'm just going to show you the four licensed integrase strand transfer inhibitors that are available to us. So this is raltegravir, elvitegravir, dolutegravir, and bictegravir. And they all have two things in common. One is they all have a metal chelating core, which chelates magnesium or manganese ions, so two valent ions that are an important part of the integrase enzyme in terms of its activity. The other thing is they all have a halogenated phenyl which interacts with integrase pocket that's normally involved in cleaving the terminal 3 base of the viral DNA before it gets integrated into the host genome. And so all of these have these two properties that make them work in sort of stopping replication of HIV. So let's look at their activity to start with. This is the integrase inhibitors in monotherapy over 7 to 10 days. As you can see, compared to all the other classes, not only are they equally as efficacious, but perhaps even slightly more efficacious in terms of viral load reduction over a 7-day period. You can see in the blue down there that of that group, dolutegravir, bictegravir, and carbotegravir are probably the three most powerful INSTIs that we have available to us. Their licensing first arrived in 2007 when raltegravir was licensed, followed in 2012 by Stribild, which is a fixed-dose combination of elvitegravir cobicistat with tenofovir and FTC. Dolutegravir came along in 2013, and then the newest kid on the block is bictegravir, which is co-formulated with tenofovir, alafenamide, and emtricitabine. And so these are the four currently licensed integrase inhibitors that are available to us. Carbotegravir is nearly here, and so watch out for that in the very, very near future, and I won't talk about that anymore in this talk. So one of the key attributes of integrase inhibitors is that they're associated with very fast declines in HIV RNA, and we learned this very early from the preclinical studies that compared to other classes of agents, the viral load reduction that we saw with integrase inhibitors was much quicker. And this is some data from a women's study called the HOPE study, which retrospectively looked at women initiating ART or intensifying ART due to detectable viremia, of whom a third were on integrase inhibitors. And you can see, compared to other regimens, an integrase inhibitor associated associated with a faster viral load decline with a median fall of 1 log over 8 days rather than 35 days compared to the other groups of agents. So what are the advantages of this faster decline in HIV viral load? Clearly there is reduced risk of onward transmission. Remember that undetectable is equal to untransmissible, U equals U, and so the faster you get somebody undetectable, the less likely they are to transmit virus onwards, sexually and in terms of mother-to-child transmission. And in both of these situations, integrase inhibitors give you a huge advantage. It's also very important in terms of engaging patient in care. If you've got them undetectable quickly, they feel that something is happening to them and that there is progress being made. But one of the questions that was asked a couple of years ago is that we know that when you look at correlates of immune restitution, inflammatory syndrome or IRIS, one of the correlates was a faster decline in your HIV viral load. And so the question was asked, would having an integrase in your regimen be associated with an increased risk of IRIS? I think there are now enough data out there, and there is at least one more randomized control trial that will look at this in the very near future. But the 3 studies we have to date, the reality trial, the optimal trial, and the inspiring study, all of which are documented up there for you, didn't show any negative impact of integrase inhibitors on the risk of IRIS or overall mortality. The inspiring study, in fact, looked at dolutegravir versus efavirenz when combined with rifampicin in the treatment of extra CNS tuberculosis, and they found no difference in the incidence of TB-associated IRIS between the treatment arms, suggesting that INSTIs were not associated with an increased risk of IRIS events. So the other thing that's an attribute of INSTIs is the efficacy. This is a whole collection of studies that included integrase inhibitors in first-line treatment, and then you can see overall the rate of undetectability, in other words, patients getting to a viral load less than 40 or less than 50 by 48 weeks has gone up since we started using integrase inhibitors. You can see in most of these studies we're now looking at between 85 to 90% of patients achieving an undetectable viral load by week 48, and this is a completely new standard in terms of what we're starting to see in registration trials. Not only is it associated with a faster decline in HIV viral load, but the response appears certainly durable over a period of many years. This was probably one of the first randomized control trials of an integrase inhibitor, a registration study called STARTMARK, which compared raltegravir versus efavirenz in treatment-naive patients. And in its primary endpoint at week 48, it was non-inferior to efavirenz. But as you go down to week 192, so out to 5 years, suddenly raltegravir appears superior to efavirenz in terms of maintaining an undetectable viral load. And so not only is the efficacy assured, but there is longevity in terms of response, certainly to raltegravir, and we're starting to get data through with the other integrase inhibitors as we go through time. So I'm just going to show you some more data in terms of studies in treatment-naive patients. So one of the issues with raltegravir was it was 400 milligrams twice a day, and so this is, twice daily dosing rather than once daily dosing. All of the other integrase inhibitors are dosed as once daily dosing, and so this was looking at 1,200 milligrams once daily of raltegravir compared to 400 milligrams twice a day, combined with Truvada or tenofovir FTC, the once Merck study in treatment-naive patients. And as you can see, there is no difference between 400 milligrams BD of raltegravir compared to 1,200 milligrams once daily of raltegravir, and suggesting that you can dose this once a day at 1,200 milligrams, so 600 tablets in treatment-naive patients. This is the elvitagravir cobicistat study. So this is looking at the fixed dose elvitagravir cobicistat with Truvada compared to Atripla in treatment-naive patients, and the efficacy endpoint, as always in these registration trials, was an undetectable HIV viral load at week 48, assessed by the FDA snapshot. And as you can see on the right-hand side, in terms of 95% confidence interval for the difference in response, elvitagravir cobicistat was non-inferior to Atripla, and so suggesting that this was equipotent as a fixed-dose combination. Similarly, the fixed-dose combination was compared to atazanavir ritonavir combined with Truvada in treatment-naive patients, and again, similarly, this was found to be non-inferior in terms of virological response at week 48. So there have been a number of dolutegravir studies, and I'm sorry the slide slipped a little bit, but you can see these are the dolutegravir studies, Spring 2, Single, Flamingo, and all showing at least non-inferiority, and certainly in two cases superiority compared to the comparator regimen. And in fact, you can summarize this in the next couple of slides. This is the newest kid on the block. This is fixed-dose bictegravir with TAF and FTC, or Biktarvy as it's licensed as, and this is a head-to-head comparison with dolutegravir plus emtricitabine TAF once daily, and there you can see it's non-inferior to a first-line therapy of dolutegravir, and this was the basis on which Biktarvy was licensed in treatment-naive patients. So you can summarize all of that data in this one slide. That dolutegravir is non-inferior to raltegravir at 48 weeks, superior to Atripla at 48 and 96 weeks, superior to darunavir ritonavir at 48 and 96 weeks, and superior to atazanavir ritonavir in a women-only study called ARIA. Raltegravir is non-inferior to Atripla at 48 weeks, but superior at 5 years, as I showed you in that first couple of slides, and it's equivalent to boosted atazanavir and boosted darunavir at 96 weeks. Elvitagravir cobicistat is non-inferior to Atripla or to atazanavir at 48 weeks, and in a women's study called WAVES, it was found to be superior to atazanavir ritonavir. Bictegravir, as we've seen, is non-inferior to dolutegravir, and so this is all of the data in treatment-naive patients in that one slide. So I'm not going to dwell very much on resistance and in genetic barrier, but just do one slide to show that there are no specific issues with integrase inhibitors with patients with high viral loads and low CD4 counts in first-line use. Raltegravir and elvitagravir have a lower barrier to resistance than dolutegravir and bictegravir, and in fact in the dolutegravir registration trials there were no treatment emergent resistance at all, even in those patients that remained viremic at week 48, and similar was the case with the bictegravir registration trials. Charles Boucher will cover resistance for you in a lot more detail. So let's look at the metabolism of the 4 licensed integrase inhibitors and think about the potential for drug-drug interactions. So raltegravir is dosed either once daily at 1200 milligrams or 400 milligrams twice daily. Elvitagravir is boosted with cobicistat and combined with either FTAF or FTDF. Dolutegravir is available either as a single tablet, 50 milligrams once a day, or as a triple combination with abacavir and lamivudine, and bictegravir is only combined with FTAF and not available as a single tablet. In terms of metabolism, raltegravir probably has the cleanest DDI profile because it's metabolized principally by the UGT1A1 transporter system. L-vitagravir, unfortunately, probably has the highest risk of drug-drug interactions because its major metabolism is through CYP3A with some minor contribution from UGT1A, 1 and 3. Dolutegravir's major metabolism is through UGT1A1 transporter proteins, although there is some CYP3A metabolism, and so there is a slight risk of drug-drug interactions. Bictegravir has got higher risk of drug-drug interactions because it uses equally UGT1A1 and CYP3A isoenzymes. The other thing about the integrase inhibitors is this issue about interacting with renal transporters and creatinine clearance. Remember that creatinine in the renal tubules is actively secreted out, and this uses two transporters, OCT2 and MATE1. And both of those are inhibited by a number of different drugs. So OCT2 by rilpivirine, dolutegravir, and bictegravir, MATE1 by dolutegravir, cobicistat, ritonavir, bictegravir, and raltegravir. And so inhibiting these leads to increase in serum creatinine because you're not able to secrete the creatinine out. Now remember that this has no impact in terms of function of the kidneys, but an increase in your serum creatinine. And so you can see this in this example. This is the SPRING 2 phase 3 trial comparing raltegravir versus dolutegravir, and this is the mean change from baseline of creatinine clearance, and you can see this was much bigger for dolutegravir than raltegravir because of that impact on renal transporters of creatinine. So increase in serum creatinine and creatinine clearance or reduction in creatinine clearance are seen with dolutegravir, bictegravir, and L-vitagravir cobicistat. These are much smaller with raltegravir, but these are not clinically relevant. In other words, they have no impact on glomerular filtration rates. It is just an increase in creatinine and the calculation of creatinine clearance. However, this may make it difficult to interpret changes in GFR, especially if the patient's on concomitant TDF. Okay, so one of the other important drug-drug interactions is chelation with cations. Remember when we first looked at the structure of the integrase inhibitors, I said one of their modes of action was to chelate positive ions on the integrase enzyme. So positive ions in the blood will chelate with integrase inhibitors, and so this is particularly an issue with magnesium, aluminium, and calcium-containing medications. And though there are some recommendations about how you should try and either avoid these concomitantly with integrase inhibitors or separate them out so that you're not getting chelation of your integrase inhibitors with the presence of these ions, mostly in magnesium and aluminium containing antacids and in calcium supplements. And so this is the data in that regard. There are also some other important drug-drug interactions. So one of those is metformin, dolutegravir, bictegravir, and to a certain extent L-vitagravir variably increase metformin exposure. So type 2 diabetic patients, you just need to be careful about the metformin dose, but no DDIs with most other anti-diabetic drugs. Rifampicin has a major issue. Rifampicin variably decreases dolutegravir, L-vitagravir, bictegravir, and raltegravir exposure. And for some of these, you cannot overcome this by increasing the dose of the integrase inhibitors. So you can do this with dolutegravir, where you double dose with rifampicin, or with raltegravir, where you can overcome this by double dosing with raltegravir, but this may not be possible with L-vitagravir and bictegravir. Rifabutin decreases L-vitagravir and bictegravir exposures, and so are contraindicated, but no clinically significant effect on dolutegravir or raltegravir. Okay, so coming up towards the end, what about tolerability? So if you look at the registration trials, and this is all out to 144 weeks and beyond, So this is how do they compare with efavirenz, tenofovir, and FTC. As you can see, for study 102, single and start mark, discontinuations were fewer on the integrase containing arm rather than on the efavirenz containing arm, and so suggesting that they were much better tolerated than efavirenz. And the same is true when you compare this with boosted PI-based regimens in treatment-naive patients. And again, so these are some of the registration trials plus the ACTG 5257 study at the bottom, as you can see, compared to either boosted darunavir, atazanavir. The integrase inhibitors seem to be better tolerated, at least in terms of discontinuation. In the 5257 study, which compared raltegravir with atazanavir boosted with ritonavir and darunavir boosted with ritonavir, raltegravir appeared better because of the risk of discontinuation from side effects. Virologically, they were all very, very similar. So what has happened to our other first-line therapies? So what has happened to efavirenz 600? So we've seen over many years of experience, and this is just data from the ACTG clinical trials of efavirenz, that there is an increased risk of CNS toxicity, particularly suicidality and suicide attempts, and that this impact was particularly high in those with a prior psychiatric diagnosis, raising the likelihood by almost 13-fold. What's happened to boosted PIs? Boosted PIs are also phasing out as first options for treatment because they have many disadvantages, and not least because of their drug-drug interactions, tolerability, side effects, and then the particularly negative impact on comorbidities associated with metabolic issues, so cardiovascular risks, non-alcoholic fatty liver disease, etc. And they may also be associated with preterm delivery. We'll come back to that later this afternoon. They do have the advantage in that they have a very high genetic barrier, and they are durable, and there is a single tablet regimen now available containing a boosted PI. So how do you choose between your integrases? This is a summary of what we've just said. So bictegravir is only available as a single tablet regimen combined with TAF and FTC, has few drug and food interactions and a potentially high barrier to resistance, but there is the least amount of safety data on bictegravir at the moment. Dolutegravir, elvitegravir, and raltegravir have a lot of data around. Raltegravir we probably have the longest experience with, has the fewest drug or food interactions, but is only available in multiple pills. In other words, even the 1200 is 2 600 milligram tablets, so there's no single tablet regimen with raltegravir. Dolutegravir, there is a single tablet regimen combined with the bacavir 3TC, has a high barrier to resistance and is active against some raltegravir and elvitegravir resistant viruses. And so for my last slide, I'm just going to put up the guidelines and where they place integrase inhibitors in terms of recommendation for therapy. And so you can see for all the major guidelines, integrase inhibitors are either the only recommended class of therapy in treatment-naive first-line use, or the preferred class, as is the case with AX. Even the WHO has now moved to dolutegravir with the option of efavirenz for women of childbearing age up to first trimester wishing to get pregnant. So I'm going to stop there and we'll take questions if there are any, but this is a summary of what we've covered. So thank you very much.